Good afternoon, everyone. Thank you for joining us today. And as a chat, could you please put your first name, last name, email, and organization of where you work? The CE office is getting a little more strict with us on those types of items. So we will start and begin with introductions. I'm Elizabeth Minnick with West Virginia Project ECHO. And then could I start with Angela Wowchick, please? Sorry.
Can you all hear me?
Yes.
Hi, I'm Angie Wojcik. I work with Rational Drug Therapy Program.
Thank you so much. Tammy?
Hi, I'm Tammy Campbell-Klein, and I work as a nurse practitioner with Cabin Creek Health Systems at Sunnyside in Charleston.
Great to have you. Carmen?
I'm Carmen Rexrode. I'm a family physician at Pendleton Community Care in Franklin, West Virginia.
Great. Thank you so much. Good to see you, Carmen. And Kaylee?
Hi, I'm Kaylee Berner. I'm a nurse practitioner working with infectious disease here at WV Medicine.
Perfect. Thank you so much. Melody?
I'm Melody Ruskin. I'm a nurse practitioner for Raynell Medical Center.
Thank you very much. Tracy?
Hi, I'm Tracy Thornsberry. I'm a nurse practitioner, Williamson Health and Wellness.
Great. Thank you so much. And Jennifer?
Hi, I'm Jennifer Boyd. I'm a physician assistant with New River Health Center working in one of our Fayetteville sites today.
Thank you so much. Dr. Gilfus?
Yeah, John Gilfus, one of the infection providers here at the hub in Morgantown. Thank you.
Thank you. Rachel?
Hi, I'm Rachel Mitchell. I'm a pharmacist here in the Specialty Pharmacy Allied Health Solutions.
Thank you so much. And Chujan Lee?
Hi, I'm one of the ID fellows here at WVU.
Thank you so much. Great to have you. Well, today we have a packed day. I'm excited. We have 2 cases, and then we'll have our didactic. So our first case we'll pull up will be with Jennifer Boyd. And Jennifer, I'll go ahead and pull that up and share my screen. Just give me a moment, please. Can everyone see that okay?
Yes, you can. Thank you.
Perfect. All right. Whenever you're ready to begin, Jennifer, go ahead. You're on mute, dear. It's okay.
Sorry, I was talking the whole time. That happens. What did somebody say last week on the presentation? My mother taught me to be seen and not heard. So I am pretty sure, oh, wait a minute. Yeah, I'm pretty sure that this case, which I haven't reviewed in a couple of weeks since I turned it in, but I'm pretty sure that this is pretty straightforward clinically, and that the key question is he is uninsured. So anyway, he is you could scroll back to the top for a second. He is a 33-year-old Caucasian male. Yes, okay, good. And excuse me, he was diagnosed in about 2014 or 15. I can't quite recall where he was diagnosed. I can go back into my notes in my chart. It might have been in prison. And the only risk factors that he admitted to, at any rate, were that he did have a partner who was infected in 2014. He had a non-professional tattoo in 2016. He had a blood transfusion in 2009. I put that in there, even though it's not likely to be a risk. But he's an interesting guy. This guy had really nice energy. It was the first time I had seen him, and he did have a history of becoming addicted to prescribed pain medication after that femur fracture, and he weaned himself off, he said, and did so successfly. Was not in any kind of program, didn't use any medication-assisted treatment. And then he had to have a C-spine surgery last fall and was given opiate pain medication after that, and again weaned himself off. He said it wasn't pleasant, but he did it. And I I found that story interesting and impressive. He works as a general contractor. He has his own business. He drinks on Fridays, but he said it's nothing he couldn't stop. He's a non-smoker. He lives alone and does not have a partner currently. He's healthy. He has an inguinal hernia that he is not doing anything about right now, but other than that, he has no other medical conditions and is not on any medication. He had Hep A vaccine when he was in prison, and he's a young guy and had Hep B when he was as part of the childhood vaccination series. His BMI was 29.5, so he's overweight. Yes, if you can scroll down to his labs. His CBC all looked normal. Glucose was normal, PTINR. LFTs were all within a normal range. As you can see there, APRI, I have this 0.2. His child trichopu class A and MELD score is 7. His vitamin D was, I believe it was on the low end of normal, and I believe I started him. It'll be in my notes on vitamin D just to boost that up a little bit. AFP 1.9. He is not HIV positive. His hepatitis C genotype is 1A, and his viral load was 5.6 million. He had a fibrosis score of F0. His Hep C surface antibody was positive, core antibody was negative, and I think that might be something I wanted to ask about. We'll see when I get to the questions. He's immune to Hep A, as I mentioned. And so let's see, I'll start with my notes. I didn't get iron studies, I just overlooked that. I did start him on vitamin D. I did not order an ultrasound, partly because he would be paying cash for it. And I wanted to ask my pharmacy partners on the call if at Allied Health Solutions, I believe you can help me with a patient assistance program. And treatment options for genotype 1A, I believe would be Harvoni, Epclusa, and Mavrite. It's nice he doesn't have any, medications that he's on, so that's not complicated. And I think that's all, except for now that I'm looking at, I guess my other question would be, now that I'm looking at those hepatitis B antibodies, I'm a little fuzzy on why he would be surface antibody positive and core antibody negative. And I'm looking in his chart now to see if I did a surface antigen. I don't think I did. So anyway, that's my guy.
Thank you so much. Per usual, great presentation, Jennifer. Does anybody have any type of recommendations or any more questions? And I can always bring that case back up if everybody needs it.
Just on a side note, I really like this guy. He was just a really sweet guy, and and he was, anxious about this, and I would really like to be able to help him with treatment.
Hey, Jennifer, it's John. I just had one little fun thing I looked up while you were talking. I don't think we ever talked about this. So his blood transfusion was in 2009. Is that what it was?
Correct.
Yeah, and I sorry, I logged in a little late. Did you did he have any diagnostic risk or any risk factors that he disclosed? Or?
So the only thing was he did have a partner who he knew had Hep C, and I should go into my note because he used opiate medication. He was addicted to, but I don't think he ever snorted, and he definitely did not use IV. That's the other interesting point in the case, is that where he got it was not quite clear to me.
Okay, well, what I was going to bring up was the fact that the magic year for blood transfusions to become relatively safe for hepatitis C was 1992.
Right.
When I look up on the CDC's website right now, because I didn't know what the current risk is, it says with the current screening tests used at blood banks for hepatitis C, the risk of transmission to recipients of blood or blood products is extremely rare, at less than 1 case per 2 million. And,
wow.
To quote Jim Carrey in Dumb and Dumber, so you're telling me there's a chance. It's uncommon, but just like they said, it's not zero. So, but very unlikely. If you ask me to guess, with a prior sexual partner with hepatitis C, that would probably be at a higher risk than his blood transfusion in 2009. And in terms of the therapeutic choices, I think they all look great. 8 weeks of Harvoni or 8 weeks of Mavorite are on the advantage of being 8 weeks apiece, because he's less than 6 million copies of genotype 1A. You could consider the short course of Harvoni at 8 weeks rather than 12. And Epclusa, again, is fine. It's just 12 weeks. Zepatier, you'd have to run the polymorphism test with the genotype 1A, and so it becomes a little less attractive due to having to do some extra blood work. So, and I'll turn it over to Rachel or anybody else who has more experience on the patient assistance programs.
Thank you, Dr. Gilfus. Yeah, and he did have that non-professional tattoo, so whether it was the sex partner or whether, he dabbled in snorting his pain medication and sharing stuff, I don't know.
Hey, Jen, this is Kaylee. I'll just tag on to what Dr. Gilfus says, and I can't believe he quoted Jim Carrey. But anyway, so one kind of interesting thing that I was just looking at recently in regards to the tattoos. So, I mean, even if it seems like he looks like he got his non-professional tattoo after he was already diagnosed with Hep C, but I would ask about professional tattoos too, because I actually had a patient just recently who got a tattoo at 16 in a parlor. But she says that the tattoo artist actually used the same needle on her and her boyfriend because he told her that they were already having sex, so using the same needle wasn't going to matter.
Oh my
and
gosh.
then that kind of prompted me to look up into regulations in terms of tattoo parlors, and it really varies widely state by state, and even as recently as the last few years. State regulations with the needles might have been in place, but sharing ink or reusing ink wasn't. So we kind of say unprofessional tattoos, but I mean, even if he had some professional ones done too, it's kind of up in the air as far as, the practices. I think in West Virginia, they're pretty stringent, but some other states, they may not have been, and just depending on the year. And I had a patient that did get a blood transfusion after 92 and actually had documentation of it. He got notification that he was that one case in 2 million. They had notified him post transfusion that the blood was Hep C positive. So it's rare, and typically they will notify the patients now. They have that in place. I don't know how that got missed, but it can happen, but yeah, it's certainly rare. I agree with Dr. Gilfus, either treatment regimen, as he said, would be fine. I would probably go with the 8 weeks Mavorite or Harvoni just because the shorter duration. As far as the insurance, usually Allied Health, they can't really do the support path or the programs to assist us if they're not insured. Sometimes your social work, if you have a social worker or a caseworker, can help them with that, or even nursing staff. But to be honest, they're usually income based. So, and it tends to be, I think, for like a household of 1 or 2, it's less than 100,000 annual income. I looked up the Maverick. I didn't look up the other Harvoni or Epclusa. Maybe Rachel knows about that more than I do, but they can either fill it out online or you can print off the form for them, but they tend to have to list some, they have to supply some of their financial information to qualify for that, but the manufacturer actually delivers the medication directly to them. And so there's not really much that you have to do other than there's a portion on each of the paperworks, depending on which regimen you go with, where you'll still have to fill out their genotype and their fibrosis level and that kind of stuff. So there is a prescriber portion. It'll still need your signature, but the patient will also have to complete their portion. So it may just be easier to do that with them in clinic or have a nurse do it with them in clinic.
Okay. Okay.
And your Hep B, yeah, you're good with that. It looks like.
I just realized that's because he was vaccinated.
Yeah,
that's
yeah.
why.
So if
Okay.
it's good to still check, because sometimes if he'd had vaccination as a child, I mean, that immunity may have waned over time, so he might have needed a booster anyway. But yeah, if he's reactive surface antibody, then he's protected, and you don't need to worry about anything else. Yeah, I knew you knew that. I knew you knew that. I think
all the
did we
moving
answer all your
parts.
questions? I think I agree. I don't think since he's really paying out of pocket, I don't believe that he would need any kind of imaging. There's nothing on his blood work that shows any concern for advanced fibrosis. His platelets are fine. APRI is unremarkable. His serum biomarkers are F0. So I wouldn't, he doesn't really have significant baseline transaminitis. So I think you can forgo the imaging. I'd feel comfortable with that. And then, to be honest, you could really even forgo the treatment week 4 labs and just check his SVR12 labs.
Okay.
Just as kind of a cost savings for him.
Okay, beautiful. Thank you guys very much. I'm kind of excited to help this guy. And I think I can have a nurse help me with the paperwork. I had to do it with one other guy, although we never got through that for other reasons, but I've printed it out once before. And so I'll figure that out with him. Thank you very much.
Yeah, and it looks like Dr. Rex wrote in the chat that they just did the paperwork for someone with Harvoni, and it was pretty easy. So maybe that would
I'll
be
check
the
on
route
that
to
one
go.
first then. That's a great tip.
It was pretty straightforward. They also, I think, will help if somebody has insurance but a Sky had co-payment, you can get help.
Oh, that's my other guy. That's interesting.
Yeah.
Yeah.
So help is out there.
Yeah, and Allied Health can help with that. I should let Rachel talk because she knows all the ins and outs of that. But with the copay assistance, the different manufacturers, sometimes they can use a copay card to bring that cost down. But if they're uninsured, it's a little bit of a different pathway. But you can still print the paperwork offline. And actually, I can actually try to get those references to Mira to disperse to you guys if you want to just have a file with those paperworks, just kind of, if you ever need them.
Hey, this is Rachel. I'll just kind of tag along with that. I actually have the email for you guys kind of drafted up here with some of the links. So I have right now just with Support Path through Gilead, so that'll be Epclusa and Harvoni. And then the AbbVie Assist program is the one for Maverick. And Maverick, the AbbVie program, they do have, just like Kaylee said, it's $100,000 for 1 or 2 households. They don't publish that information for Gilead, and they just say for Support Path that that's on a case-by-case basis. But I have seen that it seems to be relatively similar. But like Kaylee said, we don't do that here just because they do require financial documentation, tax documentation to prove income, and we don't have a social worker currently to be able to follow through with that. But I'll put the links on here for the program information and then for the forms. The nice thing too is that Gilead, for their Support Path program, if you want to use it, you can also fill out an electronic version and submit it. So rather than filling out the paperwork, if you want to do it electronically, you can do it that way as well. And then, like Kaylee said, once it's approved, they'll have some sort of either an order or prescription that you'll have to sign off on that'll go directly to them, and then they themselves or their pharmacy are contracted, so the patient will get drug directly from them, from the manufacturer. It won't come from like our pharmacy or another pharmacy like us.
Awesome. Thank you guys so much for all the legwork and the tips.
Jennifer, this is Dr. Paliwal. Do
Hi, Dr. Paliwal.
your pharmacy keeps Hep C drugs under 304B program?
I don't think so. I don't think so. You know, I can double check with them. It's a good question, actually. But most of the people I've treated, I've worked with Allied because it's just so dreamy to work with those guys. It's really a care management thing. And when I first started working with Echo, it was a little more challenging working through our pharmacy. But I can check. How about you all at Fairmont? Do you keep them?
Actually, recently I got an email from one of my staff that one of the pharmacy representative wanted to talk to me regarding a Hep C drug that is available under the 340B program. And I actually, I can put his, it's Tom Lindstrom from Evita.
Okay.
Okay, and I will give you the phone number.
Good.
Okay, I mean, I forgot to call this person, okay, and see whether, what medicine they were talking about. But I just reminded that you might have access to that 304B program and you can speak to him.
Okay, good. Can you put that info in the chat? That would be good. Great. Thank you very much.
Thank you so much, Dr. Paliwal, and thank you everyone for their wonderful input today. We'll make sure we have everything from the chat in the recap as well. And of course, you can always email questions to myself or Mitra, and we'll be happy to reach out to the correct people. All right, so in interest of time, we'll move on to Tammy's presentation. Just give me one moment for her case. Can everyone see that okay?
Yes, thank you.
Perfect. All right, Tammy, when you're ready, please.
Okay, it's good to be back today. At first I was going to have the hub just review this, but then I realized I would be here today. So this is a 32-year-old female, and she came to me a couple of months ago. She was referred by one of our other clinics, and you can see her her labs there. Everything was okay except her weight was low and her BMI is 17.5. And I'll come back to the ultrasound, but she was diagnosed with Hep C in 2017, and that was when it was really hard to get treatment. So she had gotten clean in 2015, and I asked her if she went into treatment, and she said no. She had been in this situation where she was using IV heroin, the Roxys, all the opiates. She didn't use meth or any other drugs. And she was 20 years old when she started. She said she did not share needles or supplies with anyone, but she wasn't in the best living conditions, and other people might have gotten some of her supplies or might have used some of her supplies. She has had no blood transfusion. She does have 6 tattoos, and 1 was non-professional, and no sexual contact with anyone positive for Hep C. But she said when she got clean, she had met a person who was a truck driver and just went on the road with him to get out of the place where she was living and using. And so she has been clean for 5 years, and she had 2 children by a previous marriage. And she says that she and her ex-husband co-parent the children. She does smoke half a pack of cigarettes a day and no alcohol. There's her comorbidities, asthma, that is well controlled. anxiety, depression, insomnia, and she's on medication for that. And she also is an MAT patient now, and she has been stable for several years on that. There are her meds, and I had that chlorhexidine that was used previously, and I forgot to take it out. But so she's on inhalers and escitalopram for her depression and anxiety. She is on birth control with Depo now. And her vitamin D was low and put her on it, and now it's like up to 60. It seems like it went up quickly. She is immune to Hep A and Hep B. There's her weight and height again. And you see her labs. The CBC was normal. Creatinine 0.59, glucose 92. Her ProTime and INR was normal. Liver enzymes were normal. Let's see, her APRI was 0.350. Child Trico-Pugh was 5, MELD score was 6. And there are her iron levels. Her current vitamin D, her AFP was 1.5. HIV negative. Genotype is 1A, and that is her current viral load. RA factor was negative, and her serum fibrosis marker was F0. And so I put, she has TRICARE and also Medicaid. And so I put she could have Mavorite or Epclusa, because she could have Harvoni. I'm not sure who's going to pay, or if TRICARE will pay for this. She's not on any GI meds. She has not had Hep B, but the ultrasound did show some possible sludge balls or polyps. And I referred her to see a surgeon, and that appointment has just happened. I haven't gotten results on that yet. And when I examined her, she was tender in the right upper quadrant. So I had a question if it turned out she does have stones, what should occur first, the Hep C treatment or surgery? So there you have it.
Thank you so much, Tammy. I'm very happy you were able to join us today. Does anybody have any input or further questions for Tammy?
Tammy, I'll talk if nobody else wants to. This is Kaylee. I'm sorry. I feel like you guys get tired of hearing me talk all the time. I'll let Rachel talk about the TRICARE, because I'm actually not sure which one would come first, or even I'm not as familiar with TRICARE's regimens, but Mavorite times 8 weeks or Epclusa for 12 weeks is certainly fine. And I know you mentioned Harvoni, and if TRICARE covers that and the Medicaid wouldn't have to supplant it, then that would be fine too. And you could do 8 weeks with that one. With the ultrasound, it would really depend on what the surgeon says. I mean, typically if they're small polyps, if they're less than a centimeter, they kind of just watch them. But if she's got some pain and she's possibly got some sludge, I mean, he may recommend a removal. Really, that should be the same day surgery. So, you could technically go ahead and start the process for her to get started on treatment, as long as she knows to bring the medication in with her. The other thing though is, I mean, it's not something that she would have to urgently start Hep C treatment. So, I mean, if she'd be willing to just wait a little while longer, I don't see a reason for her to have to get started before that assessment is already completed. I think the biggest thing is just, if she's got kind of post-surgical vomiting, or she, decreased PO intake, or ends up being hospitalized for a little while, she may have difficulty getting access to her treatment, so she might miss doses. That's kind of, I would probably just wait just to see, but there's not really any medical reason that she couldn't start beforehand.
Okay, thank you.
Thank you so much, Kaylee. And I don't believe anybody gets sick of hearing from you. But we need to put some more jokes in there. Maybe pull out some Dumb and Dumber like John and
I know. I wish I had his humor. I don't. Sorry.
I'm thinking like a book of jokes,
No, Kaylee would keep a binder of jokes, not a book.
That's not nice. Stop it. I love my binders. They've been so helpful.
Are there any other questions? Or Tammy, do you have any other questions? Or I think, did she mention maybe Rachel might have a little more input on that?
Yeah, I was going to jump in. Just usually, traditionally, you would, if the TRICARE is a Medicare plan, usually that would be the primary, and Medicaid would be the backup for the copay for that. So that would be the primary prior authorization you would use, and keep in mind that formulary can vary depending on the different plans. So I've seen all of the drugs that we've kind of talked about here, the different medications, Harvoni, Epclusa, Mavyret, as options on those. So depending on the plan, that might dictate which therapy you choose, and they are usually limited to specific pharmacies. TRICARE usually has contracts with like Walgreens, so I've seen some Kroger and things like that. So they might also dictate where the patient has to get the medication from as well.
Okay, thank you, Rachel.
Thank you so much. All right, just in the interest of time again, we'll go ahead and press forward to the presentation with Angela. I just want to say that I'm really grateful for you guys' cases, and we'll make sure we get those recommendations to you as well. Thank you, everybody. All right, Angela, are you ready for me to pull up yours?
Yep, sounds good. So today we'll talk a little bit about updates on medication regimens for adults with HIV, and for the sake of brevity, we'll focus mostly on newly diagnosed patients who are treatment naive, and then I'll give a brief update on a new product that came out in January. So our first slide has some of the medications approved for HIV. As you can kind of see, a lot of the early options in the treatment of HIV had some side effect profiles that were pretty harsh. They decreased the patient's quality of life. But in the 90s, with the introduction of the protease inhibitors, we started to see some real hope in terms of efficacy and tolerability of those regimens. And we have a new one that was approved and has come out in January of 2021 that we'll talk about, Cabenuva, that is a long-acting injectable. But now HIV is not a death sentence, and our patients live long and full lives that are similar in duration to non-HIV patients. So we've really come a long way in terms of treatment options for these patients. So on the next slide, so in choosing antiretroviral therapy regimens, so we want to look at our goals of therapy, and the first one is primarily to prevent morbidity and mortality as much as we can, and that involves reducing both AIDS and non-AIDS related complications and allowing the patients to have the same lifespan as a patient who does not have HIV. So we want to always make sure we are choosing a regimen that allows the patient to maintain a non-detectable viral load, and different labs tend to have different minimal measurable quantities. Some are 50 copies per milliliter, some 25, but the goal is for it to just be undetectable in the bloodstream. And we want to, of course, reduce the spread. So we want to reduce the spread to sexual partners, to infants born to mothers, and to decrease the spread through needle sharing, which is what is becoming our problem now in this day and age, that we have a lot of IV drug use, especially in the state of West Virginia. When to start therapy, the recommendations currently say to start immediately. You generally don't need to wait for opportunistic infections to resolve. You don't need to wait for resistant testing results, although it's important to still do the resistant testing, but you can start the regimen without that, especially for a newly diagnosed patient that's treatment naive. The odds of resistance are generally low. And with the new recommendations that have been in place for years, you don't have to wait until CD4 counts decline to start the patient on therapy. And this will reduce the odds of the complications, both AIDS-related and non-AIDS-related. And the magnitude of CD4 recovery is directly correlated to the patient's CD4 count when they started ART. So starting it as early as possible is always preferred. And life expectancy is generally higher for those that are started at higher CD4 counts. So we want to make sure we start treatment as soon as the patient is diagnosed. So for choosing a regimen, we generally want to go with 3-drug regimens, and you're going to usually use 2 NRTIs, and then you're going to add 1 from a third class. So you would look at a boosted PI or boosted protease inhibitor, an NNRTI, and an integrase inhibitor. And we'll talk a little bit about the drug classes. For completeness, I listed all of them that are currently FDA approved on the next slide. And we'll focus more on the top 4 because those are the more commonly used ones. So for NRTIs, so these medications work as false substrates of reverse transcriptase. They bind to the DNA chain and they stop its production. For side effects, I focused mainly on the ones that are more commonly used. Zidovudine and stavudine have some noteworthy side effects, but zidovudine is not used too much anymore other than cases that have a lot of resistance issues or in prevention of transmission from mothers to newborns. And stavudine I didn't list because it's not available in the US anymore. For side effects, hypersensitivity reactions is a big one and is very important for patients if you're considering a regimen with abacavir, which is one of the common regimens they use for newly diagnosed patients. So this hypersensitivity reaction, it can occur within 6 weeks of starting the therapy, and it causes potentially fatal hypotension. So you always want to make sure that you test to see if this patient is likely to have this hypersensitivity reaction. So you would test for the HLA B5701 allele, and that's just the genotyping test that you would always do on a patient before starting abacavir, because it occurs in approximately 5% of patients, but because it can be so serious, it's important to test that before starting that medication. For bone marrow density, you want to look at medications like tenofovir, the TDF version of tenofovir. So as you can see on this slide, tenofovir has 2 different formulations. Tenofovir alafeminate is usually more expensive and newer. It always depends on formulary, of course, but for out-of-pocket and generally for a lot of formularies, it's usually more expensive just because it's newer. You can see some weight gain with that medication. Not sure how much of a big concern it is. It probably wouldn't deter a clinician from selecting that medication. If it makes more sense due to formulary or if they're having a side effect, that might guide your therapy more so than looking at weight gain. Lactic acidosis, so that's listed on there as a class effect. This was more of an issue with the older medications in this class that aren't used anymore, but in rare occasions it can occur with some of the other medications that are newer. And I listed cardiac issues with abacavir just for completeness sake. Some post-marketing studies have shown that there are higher rates of MI, but I think generally if a clinician is looking at which medication to start and this medication makes the most sense for the patient's regimen, they'll go ahead and continue to use it anyway. The data isn't that compelling on how significant this is as a concern. So the next slide has our non-nucleoside reverse transcriptase inhibitors, and they bind to reverse transcriptase and prevent further production of the viral DNA. So I listed those options there. Rilpivirine and doravavine are the most popular medications in this class because they're available in our 1-pill formulations, and we always want to go with the fewest number of pills per day, just for simplicity of a regimen. The newer NNRTIs, the 3 that are listed last, they have more stability against resistant strains than the older ones, so they're used a little bit more commonly as well. For rilpivirine, you have to be careful if you're using it in a patient with a high viral load, and they define that as greater than 100,000 copies per ml. And it does have to be taken with a large meal for proper absorption. And you also have to counsel patients on needing to avoid PPIs, which is something that's important to talk to patients about since they can be obtained over the counter. Efavirenz is still used because it was part of the original one pill daily regimen. It's called a tripla, if anybody remembers that. And if a patient was started on that regimen and there was no need to change them, physicians generally will just continue the patient on it. So it is still used some now. But it's not usually started as a new medication for patients anymore. It's not a great option for patients who could potentially have some resistance issues. For this class of medication, the CYP450 mechanism is an issue with some of these medications. Doravirine is the least associated with these issues because it doesn't induce that mechanism, but it is still metabolized by the CYP. So we have to watch for drug interactions that might occur with other medications. For the side effects, rash can be a class side effect. CNS side effects can be an issue. Doravirine causes the least, but the side effects that we're generally looking at are dizziness, vivid dreams, suicidal ideations, hallucinations. They're most closely associated with the efavirenz, if you would be considering that for a patient that may already have some mental health issues. For pregnancy, efavirenz, they say it's not the best option to select if the patient is potentially trying to conceive. The warning is primarily for patients in their first trimester, but clinicians will generally go ahead and use it if the patient has already been on the medication and it's the best drug option for the patient. And a lot of times there's no issues with using that, but it does have the warning, so I listed it. For dyslipidemia, we usually more closely associate this side effect with protease inhibitors, but efavirenz can cause some of those issues as well. For protease inhibitors, these are going to inhibit the breakage of the polyprotein so that the mature viron can't form, and I listed those options there. You always have to have a booster with this class of medication, and some of them are co-formulated, so I listed those on this slide. So they came out in 1995, and they brought a lot of hope to the treatment of HIV because they could be combined with the NRTIs for more effective treatment. There are a few more in this class, but they aren't used so much anymore, so I listed the most commonly used ones here. Ritonavir is actually a protease inhibitor, but it's not really used much in therapeutic doses, just as a booster in lower doses. So if you use a booster with this class, it helps with frequency of dosing. So it's not ideal to dose medication 3-4 times a day. So with the boosters, they can be dosed fewer times per day, which is always ideal. So the PIs are a very potent treatment option, especially if the patient might have a drug-resistant strain. It usually requires multiple mutations to limit the use of this class of medication. So that's kind of the appeal of using a protease inhibitor. Looking at the side effects, bone density can be a class effect. They note some osteoporosis or osteopenia with some patients with this class of medication. GI intolerance, diarrhea, nausea, and vomiting can be noted. Diarrhea is noted more in the lopinavir than the other options in the class. Fat distribution and dyslipidemia can happen with all boosted protease inhibitors. The buffalo hump was a typical thing that they would note with patients with PIs in the past. Hepatic side effects, you always want to be cognizant of that, especially if you're treating a patient maybe with some substance use disorders, depending upon what they've been using. Renal side effects, atazanavir can cause kidney stones. So if you have a patient that's more prone to those, if you would prefer to avoid that medication or just make sure that the patient's counseled on properly hydrating, that can help with that. On the next slide, we'll talk about integrase inhibitors. So these medications inhibit viral enzyme integrase, and they block the insertion of the viral DNA into the host cell. So I listed 4 options for this class here. This class does have an interaction with cations, so that's something to keep in mind with counseling for patients. So you want to separate them from iron, calcium, multivitamins for a few hours with their dosing. So raltegravir has relatively few drug interactions, so it's a good option if you have a patient on a lot of other medications or in whom that might be a concern, but it does have to be dosed BID, so it's not generally the first choice for most patients for that reason. Alvategravir must be given with cobistatin, so that's something to keep in mind with that option. Dolutegravir, in patients who are not integrase inhibitor naive, they can require multiple daily dosing, but generally if the patient is integrase inhibitor naive, then they do okay with daily dosing. And with this class, you want to watch for CYP drug interactions as well. For side effects, GI intolerance, nausea, and diarrhea can be associated most closely with elvitegravir. I listed neuro 2 defects, and this is a little bit of the change in the guidelines that I'll highlight in a couple of slides, but for right now, we'll mention it. With good prenatal care and folate supplementation, this is usually okay to use dolutegravir in pregnancy, but there was an update in the guidelines since the last revision. The previous guidelines did not recommend using it in patients in their first trimester. So on the next slide, we'll talk about selecting a regimen for a newly diagnosed patient. So the things that we want to consider are pill burden and then food restrictions, because studies have shown that the fewer number of pills and the fewer daily doses that are needed improve compliance, as does having to watch food restrictions, not having that burden as well. So if you have to take it with a big meal, it might affect absorption if the meal isn't quite big enough, or if they have to wait until their meal, it might delay them taking their medication, or they might forget it altogether. So whenever we can avoid those things, it's always more optimal. We definitely want to look at efficacy, because we have to have the viral load undetected, and if it's not, the regimen should definitely be changed or altered. And then you also want to look at the side effect profile. So we want to make sure the patients are happy and feeling good and having good quality of life with their regimen. If not, it might be time to simplify or change their regimen. And a lot of times that does come up, when to simplify it. So sometimes patients have been on medication regimens for a while, and there might be something that's simpler or requires fewer numbers of dosages during the day. So you kind of ask when would be appropriate to switch. So if their viral load is suppressed, that is a good time to switch. If their viral load is not suppressed, of course, it's time to figure out the most effective. But if their viral load is suppressed, that's the time you can switch. If the patient's unhappy with their current regimen for some reason, maybe it's not conducive to their lifestyle, taking 2 pills a day as opposed to 1, or if they're having drug-drug interactions, that's something to look at as well. So these are the 5 regimens that are recommended for initial therapy for patients who are treatment naive and newly diagnosed. So I'll just kind of highlight some of the things on these 5 regimens. So if you start the regimen that includes abacavir, as we talked before, you want to make sure that you test for that allele and make sure that they are negative. And then for the dolutegravir, abacavir, lamivudine regimen, they also need to not be co-diagnosed with hepatitis B. There is a 2-drug regimen that's now in the guidelines that's recommended as initial therapy for newly diagnosed treatment-naive patients. So that is our 4th regimen listed on this slide, dolutegravir, lamivudine. So we have to have some things in mind before we start this regimen. We have to make sure that the patients have an RNA load of less than 500,000 copies per ml. They cannot be co-infected with Hep B. And then we also have to have genotype testing before we start this regimen. This is kind of the caveat to that, that you don't have to have the resistance testing. If you're going to start this regimen, you do have to have that back as recommended in the guidelines. And this is added since the last revision of the guidelines based on the data from the Gemini 1 and 2 trials, which showed that the 2-drug regimen had similar efficacy to the 3-drug regimen of dolutegravir, TDF, and lamivudine. And these are effective the update of December 2019, which is still currently up to date. So I'll talk about a couple of types of patients that we want to look out for in selecting new antiretroviral regimens. And we have a lot of substance use disorder in West Virginia, so I thought it would be good to highlight that and some of the things to keep in mind when selecting regimens for those types of patients. The question comes up a lot, do we need to delay starting antiretroviral therapy because of ongoing substance abuse? And the guidelines do still state we don't need to delay, and these patients could potentially be spreading the disease. So we want to make sure that we definitely get them treated and counseled and do the best we can for those patients. We want to select the most simplified of treatments that while still selecting something that would be efficacious for the patient, but ideally something single dose once a day that doesn't have to be taken with regards to food whenever possible is the best option to select, as well as something that has a high barrier of resistance and low risk of hepatotoxicity, depending upon what type of substance use disorder the patient has. Avoiding hepatotoxic drugs is usually ideal. You want to always keep their comorbidities in mind. So do they have liver disease, Hep B, Hep C? Discuss adherence with the patient. So these patients in particular are important to counsel and educate, and then watch for drug interactions with maybe some of the illicit substances they might be on, as well as some of the medications that they might be on to treat their substance use disorders, so buprenorphine and methadone. And selecting ART regimens in older patients is something to keep in mind as well. We want to make sure that we keep an eye out for potential drug interactions, as well as some disease states that these patients might be aging into. And also keep in mind that these patients have a greater potential for adverse effects on renal, liver, cardiovascular, CNS, metabolic, and bone health, just due to their age. So if the patient's at a greater risk for osteoporosis, you might want to consider alternatives to TDF. And some of those alternatives that the guidelines recommend can be abacavir, NRTI-sparing regimens, or the tenofovir alafenamate formulation. If the patient's not treatment naive and enters menopause on a regimen that has greater likelihood of decreasing bone mineral density, this might be a good time to switch or simplify their therapy regimen. And that might be when a medication review is pretty helpful for the patients, because it might be time to change if they are at a patient who's at high risk for fragility fractures. So we want to look at the disease states they're aging into. And it's really important to keep in mind. So it's unknown if drug accumulation is in older patients leads to more occurrences of adverse effects, but they are a particularly vulnerable patient population. So it's something to just kind of keep in the back of your mind. And you just want to monitor kidney and liver function as well. So selecting ART regimens in women, so they have special recommendations depending upon where in their life the woman is, and if they are a patient who's trying to conceive, if they're not trying to conceive, but they are sexually active and not using contraception. So the guidelines have some special recommendations there. The dolutegravir regimens are now recommended by the panel as recommended versus they were previously alternative regimens, depending upon when in the pregnancy that the patient presents. And as we talked about before, if they're on a good folate regimen, they've had good prenatal care, it's generally okay. And the next thing I wanted to talk about, I think, yeah, we still have some time. There's a new medication that came out in January, so I wanted to touch on that just a little bit and give you guys an update on that medication. So this is the first long-acting antiretroviral product for HIV. Cabenuva is the brand name of it, but it is an injectable form of cabotegravir and rilpivirine. So this is going to be a monthly injection. You have to have the patient on an oral medication for 30 days of the two components of the medication before you can start the injectable, just to make sure that they tolerate it well. The patient selection, you should only use this in patients that are virologically suppressed on a stable antiretroviral therapy regimen. So this is probably not going to be used in a newly diagnosed patient, but this is an option for a patient that might have some compliance issues and is already virologically suppressed. They say for roughly 3 to 6 months. They're not hard and fast on that 3 versus 6 months, but we definitely want to make sure that they're virologically suppressed before starting this. They don't recommend it in patients who are pregnant or planning to become pregnant, no previous virologic failures, and no active Hep B infections unless they've got an oral Hep B medication on board. So they're injecting every 4 weeks. It does have to be administered in a clinical setting. It's probably going to be given in either a clinic or a physician's office, and it is an intramuscular injection. They're hoping that it will improve adherence and reduce pill fatigue in some patients. There are some things to keep in mind with it. So it does require that 30-day oral initiation, but cabotegravir oral is not really generally available from pharmacies. So you do have to go through the drug company. It's ViiV Healthcare, it's VIIV Healthcare, and they provide that with no problem, but you do have to reach out to them to get that initiation therapy. And on the next slide, so another thing to keep in mind with this is they can receive their doses 7 days early or late. So if they maybe are going on vacation or they have something going on in their life where they know that they're not going to be around for that period. You have a window for receiving the injection. If they just fall into major non-compliance and they miss that window, they do have to do an oral bridging recommendation. And again, the thing to keep in mind with that is that cabotegravir oral does have to be obtained through the drug company. So it's not quite as easy as just writing a prescription and sending them to the pharmacy. But the drug company does say that if the patient knows that they'll be out of pocket for longer than that 14-day window, they can provide that ahead of time. But for the patient that has major compliance issues and can't be dependent upon to come to the clinic, I don't know that it would be the best option, or you might want to just have that bridging therapy already ordered for the patient. There is a hub that they have that you can go to kind of coordinate everything. So they do the coordination of giving the clinics and the patients the oral medications. They do patient assistance for eligible clients. They do injection appointment reminders. And they do planning for missed doses through the website also. So due to the administration needs, this is pretty new out. The insurers are likely to cover it as a medical benefit, but it's definitely going to depend on the insurance. As of right now, Medicaid covers it as a medical benefit at this time, so it's not something that's billed at the pharmacy. For Medicare, they're expecting it to be covered as Part B, but some Advantage plans with Part D might opt to cover it as a pharmacy benefit, and it's of course always just going to depend on the plan. And that's kind of all I had for today. Does anybody have any questions?
Thank you so much, Angela. That was a wonderful presentation, and you did do really great on time. I know, no pressure at all. We do have a couple minutes, so if you have any questions, or what type of questions you have, or any comments, please feel free to do so in the chat or just speaking out loud.
Yeah, thanks for that. This is John. You know, the injectable agents have long been promised, and unfortunately, this particular regimen seems really not with the advantages that we were all hoping, with having to be monthly. So I think it's really would be exciting when we have options that were maybe every 3-month injections or longer implantable type of medications, but monthly injections of I think 3 cc's or something. It's impressive doses, or impressive size of the injection too. It's not going to be terribly attractive, but at least it's a concept. Getting into some injectable agents that are more long-acting is promising. Hopefully we'll have every 3 months someday. That's going to be a game changer.
Absolutely.
There's this is not FDA approved as an indication at all either, but you know, there's some early data that looks at cabotegravir for PrEP with pretty good outcome data coming out of pre-published trials in Africa. So that's a really potentially more exciting application for these injections, would be something like PrEP as well. But don't do it yet.
Thank you so much. If there aren't any further comments or questions, then my only announcement today is the next session will be taking place on April 8th with Judith Feinberg presenting on diagnosis and staging of HIV. Again, I appreciate everyone's time today and joining us. Thank you very much. If you need anything, please reach out to us. Have a great rest of your day.
Thanks, everyone.